Good afternoon, everybody, and welcome to today's webinar. We have Dr. Balian with us today, and I will let him introduce himself.
Hi, guys. Thank you for your time. I'm Dr. Harry Balian. I'm an interventional cardiologist. I've been the director of the cath lab at Adventist Health, Glendale, since 2007, and the chair of cardiology since 2015. During my tenure here, our cath lab has exponentially grown, not only in size, but also the caliber and the amount of cases and the type of cases that we are providing our community with. We used to be sort of a center where we put stents in the heart arteries, which we still do. We are a STEMI center where people come in with heart attacks and we take them to the cath lab, try to open their artery within a timely manner, very short time. The sooner, the better. Secondly, we are a stroke center where we are able to take patients that come in with a stroke, take them to the cath lab, open the artery that's been blocked, causing the stroke. We do peripheral cases where we take patients that have blocked arteries in their legs and open them up, put a stent. A lot of these cases I actually try to do minimally invasive, where we go to the wrist and go down to the legs, open the arteries. Same thing with the hearts. We go to the wrist and open the arteries to the wrist and put stents. So the other major things which I want to focus on today is structural heart. Structural heart entails problems with the actual heart itself, namely the valve disease, valvular deterioration, and valve replacement, where traditionally we used to do this with open heart surgery, where they had to cut the chest open. Now I can do this with going to the groin and putting a new valve inside the old one, where the patient stays overnight and goes home the next morning. We also can go and repair the existing valve, like the mitral valve that becomes leaky and doesn't close well. We go in and put a clip on top of the valve, and then actually the valve integrity is preserved and patient can go home the next day. And then lastly, I want to touch up on Watchman device. Watchman device is actually a device that's geared for people that have irregular heart rhythm and they cannot take blood thinners. We actually can go inside their heart, put a small plug in the left upper chamber of the heart where there's a little appendage where clots mostly accumulate. We can put a plug at the mouth of the appendage, and that actually will then take the need away of these patients having to be on blood thinners. As we know, blood thinners, it's a double-edged sword. If people take them, they'll be protected from having embolic stroke. But if sometimes people fall and bleed in the head, sometimes people have gastrointestinal bleedings, etc., where they cannot take blood thinners. So with that said, I'm going to start. First, this is going to be, unfortunately, because of time constraint, I'm going to go through my slides, and then we will take questions. And I actually have a procedure scheduled at 1:40, 1:45. So I have to make a hard stop at 1:40 so I can go and do the case. So I apologize for that. So with that said, I'm going to talk about, there we go. So my objectives are today to talk about aortic valve stenosis and talk about, then jump into treatment of mitral valve regurgitation. And lastly, talk about the Watchman procedure as I mentioned. So the heart has four valves. On the right side of the heart, there's a tricuspid valve and a pulmonic valve. On the left side of the heart, there's a mitral valve and aortic valve. The aortic valve is a valve, the last valve through which blood exits from the heart into the body. And as people get older, their valves have wear and tear. And the most commonly, the aortic valve is the one that's involved, where people, as they get older, they have calcium buildup on the valve leaflets where the valve doesn't open well. So this is the aortic valve that normally looks like an inverted Mercedes sign. And as people get older, there's calcium buildup. The valve itself almost looks like a puckered up lips where the valve leaflets are fused and they don't open well. So as people get older, they basically have a higher chance of developing calcium on their valve leaflets, and to the point where the valve doesn't open well. When the valve doesn't open well and the heart is pumping high pressure against the valve that is calcified and basically fused together, the heart muscle can get damaged where it becomes hypertrophied and thickened, and eventually people can go into heart failure. Previously, the only solution for this condition, aortic stenosis, was surgery, where people had to have their chest cut open and the valve taken out and a new valve put in. And of course, a lot of these patients are very much, they're older and they're frail. They may not tolerate surgery. So the surgeons a lot of times would say, you know what, you're too old for surgery. So you live the remaining days of your life and take your Lasix and good luck. So now we can give a new chance to life to these patients. Actually, I have a 95-year-old, still very functional patient, going on to 96 in 3 months. She was having heart failure symptoms almost frequently every other week. And she was admitted to a nearby hospital. So we transferred over, and I did her angiogram yesterday. And she had blocked arteries. We put stents in her arteries. And this Friday, we're going to do a TAVR. She has severe aortic stenosis. Her valve is barely opening. So we're going to go through the groin and put a new valve. And essentially, this will give her a new lease on life. I mean, you can make the argument she's 95 going on to 96, but I believe an age is just a number. You know, you can. I have patients that are in their 90s and they're basically like they're in their 50s, and I also have patients that are in their 50s. They basically act like they're in their 90s. So again, age is very much a number. It depends on the patient's overall functional capacity and their willingness to move around and do things. So a lot of times aortic stenosis can be congenital also. People that have, instead of 3 leaflets, they can be born with 1 leaflet or 2 leaflets. And those patients are going to be prone to having aortic stenosis at a young age. Whereas the most common type of aortic stenosis is it's called the senile degenerative AS, where as people get older, their valve becomes more dysfunctional because it's the wear and tear situation. In fact, 70% of people in their 70s have some level of aortic stenosis, and then this is essentially something that they should pay attention to. So when we look at a healthy aortic valve, it's a tri-leaflet. Basically, you have the right coronary cusp, right coronary cusp, left coronary cusp, and non-coronary cusp. As people get older, the calcium builds up on the actual leaflets, and you go from having a nice, smooth-looking aortic valve to a puckered up aortic valve leaflets that are fused together. So as I mentioned, when this is the heart, and this is the right side of the heart, and this is the left, and we have basically the tricuspid valve, the pulmonic valve, and then on the left side of the heart, we have the mitral valve and also the aortic valve. The aortic valve is a valve through which blood exits from the heart into the body. And as this aortic valve gets thicker and dysfunctional, the heart muscle can become thicker. And eventually, people have what's called subendocardial ischemia, where they can have a heart attack simply because the heart muscle is so thick and the heart cannot generate enough blood to supply blood flow to the thick heart muscle. And people actually they don't do well. When people have symptoms of heart failure, symptoms of chest pain, symptoms of syncope where they pass out with aortic stenosis, severe aortic stenosis, their survival is 2 to 5 years. 50% die within 2 to 5 years. So this is a very serious problem. When people develop heart failure and they have critical aortic stenosis, 50% of them will be dead in 2 years. So we have to basically do something about it. So the symptoms of aortic stenosis are shortness of breath, syncope, or people just simply pass out. They can develop chest pain, they can develop heart failure symptoms. And as I mentioned, if you don't jump on this right away, within 2 years, a lot of those patients will be dead. So so timely intervention is critical for patients with symptoms, as I mentioned. And because if we sort of let things go, the heart muscle gets weaker, gets enlarged, and the patient can basically have sudden death. So this is basically the way to treat aortic stenosis without surgery, without having to have the chest cut open. We actually advance a catheter and a balloon across the aortic valve. We balloon the valve open and push the calcium away from the leaflets, and then we deploy a new valve on top of the old one. This is called TAVR procedure, transaortic valve procedure, where we basically replace the old valve with a new valve without having to cut the chest open. And this is a procedure that takes about 30 minutes, and then subsequently the patient is in recovery, and the next morning they go home. I did 2 TAVRs yesterday, and then the patients are in their 80s, have had recurrent heart failure symptoms, and the procedure, each one took about 30 to 40 minutes, and then the patients have both been discharged and they're home right now. And automatically they feel a whole lot better, and they're able to breathe better, and they have better functional capacity without having to have open heart surgery. So this is one of the valves basically that it's like a spring. It opens up like a stent, and inside of it there's a new valve. Basically, it's a pig valve that's basically sewn inside this stent. And as we go in the cath lab, we're able to visualize where we're going to deploy. Obviously, we have to be very careful in our landing zone. If we deploy the valve too high or too low, we can create a lot of problems where we can obstruct the coronary arteries, or if it's too low, it can be basically embolizing inside the left ventricle, and it can actually create a catastrophe. So also, this is kind of just the tracings inside the cath lab. We have high pressure readings inside the heart and outside because there's an obstruction in the valve. Once the valve is replaced, you see that inside the heart and outside of the heart, the pressure tracings are essentially the same, meaning the obstruction is relieved after the aortic valve is replaced. So this is basically a trial that brought the TAVR valve on the map, the PARTNER trial. I don't want to get too detailed, but this was a landmark trial that showed that the TAVR procedure, as compared to the open heart surgical valve replacement, was much safer. There was a lower mortality, and basically hospitalization stay was much less. And then the patient's overall quality of life is better. They're out of heart failure almost immediately, and they actually do well. So this is, again, for relief of aortic stenosis and patients with aortic stenosis, that you basically can have the TAVR, the valve replacement, as putting a catheter and a new valve across the old one. The mortality is lower. All-cause mortality 1.1%, and disabling stroke 1%, and it's 75% lower than open heart surgery and valve replacement. So as I mentioned earlier, patients with aortic stenosis can have essentially syncope, anginal symptoms, CHF symptoms, fatigue, slow gait, decreased exercise tolerance, all of the above. And the actual most common location where we do the TAVR is we go through the groin, we advance the catheter across the aortic valve, and we deploy the valve. I have had situations where the patients have severely diseased arteries in the leg, and then at that point we would have to go either to the subclavian artery, or I did one case where we had to expose the chest wall and had to puncture the heart directly and advance the valve through the heart and replace the valve that way. So this is the first aortic valve replacement, TAVR. This was done in 2002. Dr. Cribier in France was the first, the inventor of the TAVR valve, and this is the first patient that had the aortic valve replacement in 2002. Since then, we have made tremendous progress, and not only in making the valve much more amenable to being delivered safely, and but also a lot of centers all across the U.S. and the world now are offering this technology. So in 2010 is when the PARTNER trial led to the approval of the TAVR valve, and since then we basically had different generations of the TAVR valve, and then we have more and more, this technology becoming more and more amenable to different hospitals. I started the TAVR program here at Glendale Adventist 2016, and since then we've done a tremendous amount of TAVRs. And then also we started the Mitral Clip program, which I'm going to talk about, and the Watchman program that was a couple of years ago. So over the last many years, we made great strides and great progress to offering our patients the latest technology and being able to take care of their heart and their heart condition in a minimally invasive fashion and a safe manner. So over 150,000 patients have been treated worldwide, and over 50,000 patients treated in the United States, and in over 65 countries this TAVR is being offered. So this is basically the valve. You have the struts, with kind of a stent like you would put in the coronary arteries, and inside of it there's a new valve that basically is sewn in. And this is crimped through a catheter, and we advance it across the valve, and then we deploy it. Once we deploy it, it basically smashes the old valve leaflets And now you have a new valve inside. So this is kind of a demonstration of the actual procedure. Can you guys see it? I hope. So basically, we have the patient laying on the table, and this is their aorta, and we're advancing this catheter across the aorta and across the aortic valve on a wire, and then we basically pace the heart at 160 or 180 beats per minute, to the point where we have to almost stun the heart for a few seconds so the valve doesn't embolize. So now we basically balloon and open the valve, and then we advance the actual stent valve. This is the actual catheter, and then we have the actual TAVR valve here, and we prepare it, and then we're able to advance it across the valve. So this is the valve being crimped and prepared inside the body, and then we advance everything as a unit across. There we go. It's being advanced, the aorta, and across the aortic valve, which is calcified. So once we're across the aortic valve, as such, we align it as where we want it. Here we go. This is the valve that's crimped, and now we pace the heart at 180 beats per minute, and the heart is kind of stunned. And then we deploy the valve. And here we go. The heart is now being paced. So as it's paced, the blood pressure drops below 50. Now we're able to deploy the valve like a stent. And then basically the balloon is deflated. The heart now is the pacemaker that's pacing the heart at 180 is basically disconnected. And then now everything is in order. Patient has a new valve. This catheter is taken out of the body. And the catheter, the hole that we made in the artery when we advance the catheter, we have two sutures that we pre-deploy, and then as soon as the catheter is out, we cinch the sutures. So there's no cuts made, there's none of that. And then the patient in a couple of hours can get up and start walking, and they have a new valve. And this is a new valve that's opening and closing, and on top of inside the old one. And this is basically the latest technology with the TAVR, and then the patient essentially is doing well, and then they go home the next day. So the most common approach is the transfemoral approach, where we go to the groin. As I mentioned, and when somebody has really bad vessels or they don't have access to the peripheral artery, we can actually do a transapical approach where we stick the heart directly, deploy the valve, and then pull out the catheter and then put a stitch on top of the heart. Or we can go through the subclavian artery as well. So again, after the follow-up, patient is on aspirin and Plavix for 3 months, and after that, they'll be on a baby aspirin lifelong. So this is actually a case, 88-year-old patient with severe aortic stenosis, seen by the surgeon, deemed not a good surgical candidate. EKG is done. Angiogram shows clean arteries, and the aortic valve area being 0.8 is consistent with severe aortic stenosis. The echocardiogram, this is the aorta, and this is the aortic valve, highly calcified aortic stenosis. And we did a CAT scan, measure the diameter of the aortic valve, and so we can appropriately size what size valve we're going to put in. And after that, we basically go ahead and do a CT angiogram, look at the anatomy, making sure that the peripheral arteries are amenable to us being able to advance the catheter. And then basically we then go ahead and deploy the aortic valve. And as such, this is the aortic valve already deployed inside the old aortic valve. And this patient did very well, went home the following day, and I've been seeing her in the office. She's actually doing very well. Her heart failure symptoms have essentially resolved and gone away. So for the sake of time, I'm just going to switch gears and talk about mitral valve. And sorry, just skipping. So the mitral valve is, instead of a tri-leaflet like aortic valve, is bi-leaflet. It has 2 leaflets. It has the anterior and posterior leaflets, and it separates the left atrium from the left ventricle. The mitral valve can have stenosis. It can have regurgitation. Stenosis means the leaflets are sort of calcified and they're not opening well. This usually happens in patients in third world countries that have had rheumatic fever. It can also have regurgitation where the valve leaflets don't coapt well, and a lot of the blood as the heart pumps leaks back to the upper chamber of the heart. The patients can develop shortness of breath, can develop heart failure symptoms. So this is again the mitral valve, and you see that the mitral valve has two leaflets, and the leaflets are basically connected to the left ventricle like a parachute, and the strings. You have the chordae tendineae, and you have the papillary muscles. Just imagine like this is a parachute, upside down parachute. So what happens is when you have any kind of a damage to the chordae, and when the patient has had prior heart attack, that actually can impair the valve leaflet overall integrity of it, and patients can develop valvular regurgitation. Also, if patients have had a prior infection like endocarditis, valve infection, as the infection heals, the valve leaflets can scar, and the valve can either not close well or not open well. And they can have mitral stenosis or mitral regurgitation or both. So looking at the overall cross-sectional anatomy of the heart, imagine the heart is sliced in half from top-down view. You're looking at the aortic valve, which has tri-leaflets as mentioned. You're looking at the pulmonic valve, and we're looking at the mitral valve. The mitral valve itself has two leaflets, whereas the aortic valve has three leaflets. The mitral valve has the anterior leaflet and the posterior leaflet. And this is again sort of a echocardiographic view of the anterior and posterior leaflets. Looks like a smiley face. And when patients develop leaky valve and they have a weak heart, they basically become intolerant to valve repair through the traditional approach where they have to have a sternotomy. So the new technology is called Mitral Clip, where we actually go to the groin, puncture from the right upper chamber to the left upper chamber, and then deliver a device that actually is like a stapler. It's like it goes in and goes across the mitral valve and it opens up like a stapler device, and then brings up the two leaflets, and then puts a staple in between the two leaflets, making the leaflets kind of coapt together, and then taking away the mitral regurgitation, where a patient go from having severely leaky valve to mild or minimal leak. And this is done without cutting the chest open, and the patient again goes home the next day, and they almost automatically feel better. This is a patient that basically has mitral regurgitation. You see this blue jet. This basically means the two leaflets of the mitral valve are not coapting well, and a lot of the blood as the heart pumps, this is left ventricle, is leaking back upwards into the left upper chamber of the heart. Patients with mitral regurgitation develop shortness of breath and heart failure. This is almost inevitably most common symptom, because a lot of the blood as being pumped is trying to be pumped out of the body. Half of it is coming back to the left upper chamber, and then their lungs get congested, their lungs get wet, and patient goes into heart failure. So there's two types of mitral regurgitation. There's degenerative MR and functional MR. The degenerative MR means the valve leaflets are degenerated, and then they can have prolapsed leaflets, and then patient develops mitral regurgitation. Functional MR is when patient has dilated heart and cardiomyopathy, and the valve leaflets, although they're healthy, the heart is so enlarged that the valve leaflets don't coapt well together, and then patients can develop mitral regurgitation. So basically, the way to treat this is the clip, as I mentioned, and you know, this is basically a slide showing that patients with mitral regurgitation, they progress to heart failure, and then that itself can entail a high chance of mortality, 1 year mortality up to 57%. So for the sake of time, I'm just going to show you guys a couple of pictures as to how the mitral clip is done, and just skip through this here. So the mitral clip is approved in the US for patients with severe primary MR or secondary MR. I just want to say that mitral regurgitation can be due to old heart attack involving the middle artery of the heart. It can be due to a valve infection, rheumatic valve disease, and then degenerative mitral valve disease, mitral valve prolapse. So as we see in this diagram, when the mitral valve becomes leaky, when the heart is pumping blood out of the body, a lot of the blood can be leaking back into the left upper chamber of the heart, and the lungs get congested. This is a patient with basically severe mitral regurgitation. This is left atrium, left ventricle, and this is the actual clip. The mitral clip device is basically like a stapler. It's a staple that we deliver across the mitral valve, and this clip goes across the mitral valve, and we basically drop these grippers. Let's imagine upside down. We're going across the mitral valve, and we open up the actual clip device, and then we drop the gripper. So the leaflets get sandwiched between this upper teeth and the lower part of the staple, and then this staple device is deployed like a clip, and then basically the valve leaflets go from ellipsoid shape to almost like an alien looking two little orifices, as it has a clip in between. And the clip is then delivered, and then the device comes out of the body, and patient's leaky valve goes from severe leakiness to no or minimal leak. So basically, just for the sake of time, I'm just going to go through this. This is the actual device. It looks like a rocket launcher. It looks kind of scary, but this is basically, we go to the femoral vein in the groin, and we advance this across to the right upper chamber, then to left upper chamber, and then across the mitral valve, and then deliver this clip. And all of this stuff is basically to orient us as we go inside the heart. And all of this levers and bells and whistles are just basically have a special purpose to get us through across the mitral valve, and then finally deliver the clip. So this is basically the first step is to look at the under transesophageal echo, to look at where the gate is between the right and left upper chambers of the heart, and we pick a spot where we want to be exactly at a spot where we're not going to puncture and damage the heart. So we puncture across, then we deliver. This is basically under transesophageal echo. We've already punctured across from, this is the right upper chamber, left upper chamber. We puncture across, then we advance our wire, and we advance our catheter, and basically then we have our clip. We orient this downward. This is where the left atrium and left ventricle is, and we orient this device. This is the clip, and we orient across the aortic mitral valve, and then we deliver the actual clip. This is the clip across the mitral valve. This is the mitral valve. This is the left ventricle, and then the clip subsequently is delivered, and the patient basically their mitral regurgitation goes from severe to minimal or none. This is an echo view of the mitral valve, and this is the actual clip across the valve, and we're sort of positioning it to the point where we can safely grab the two leaflets and then deliver and deploy the clip. So the last thing I want to do is actually talk about the Watchman device. The Watchman device is a left atrial appendigeal closure device. It's basically designed for people that have atrial fibrillation, irregular heart rhythm, and they cannot tolerate blood thinners. And this is basically a device that is deployed, and it essentially takes closes that appendage, the entrance of it, and patient can safely come off of blood thinners, and only will be on baby aspirin. It's a procedure that takes about 20-30 minutes. Again, we'll go through the groin, we puncture across from the right upper chamber to the left upper chamber of the heart. We isolate where that appendage is, and we go in and we deploy this device at the gate of the appendage, and then this is basically the left upper chamber, and we've already traversed across from the right to the left upper chamber of the heart, and then this is the appendage, and then we deploy this device at the gate of the appendage where all the clots accumulate. And once we deploy this, the patient does not form any more clots because there's nowhere for clots to sit, and they can safely come off of blood thinners. This is again on the echo view. This is the appendage. We measure it, we take a picture, and then we end up subsequently.
Dr. Balian, I don't think they're seeing the right slide. We're just seeing question and comment slide.
Oh, really? Oh, I'm so sorry. What? I think I don't know what happened. Sorry about that. How about now? I'm sorry about that. I thought you guys were. Maybe I need to
Share your screen again, maybe.
Yeah. How about now?
Yeah, Yeah, okay.
Okay, so I'm sorry about that. We went through, so this is basically a procedure where we're delivering this device in the left upper chamber of the heart where the left atrial appendage is. And this is designed for people that have atrial fibrillation, irregular rhythm, and they cannot take blood thinners. So we basically put a transesophageal probe. We puncture across from the right upper to left upper chamber of the heart, and then we're able to deliver this plug and to put the plug on the gate of the appendage. And after that, patient comes off of blood thinner safely. And then within about 45 days, this tissue develops on top of the plug that just becomes part of their own heart essentially. And patients can safely come off of blood thinners without having a chance of stroke. So I'm going to stop. I'm going to take questions for the next 10 minutes or so, and then we'll call it a day.